I do want to move on to our next speaker. And also just to add, I know these stories, this is a really sensitive topic, will have impacted on so many people listening. So again, please do take the time to look after your own mental health and well-being. I am really pleased to be introducing our next speaker, Professor Louis Appleby. So Louis probably will need no introductions. He's the lead for the National Suicide Prevention Strategy for England. He's the director for the National Confidential Inquiry. He leads the Centre for Mental Health and Safety. But I should also add, Louis, you were knighted in the 2023 New Year's Honours List. I'm sure many people will want to pass on their congratulations for your contributions to medicine and mental health. So over to you, Louis, and congratulations again.
Well, thank you very much. Thank you very much, Prativa. Thank you for coming today and for joining our conference. Can I also start by thanking Ian Russell for such a moving and powerful story, and Ian also for your incredible campaign on behalf of Molly, but also on behalf of other young people and their safety. I'm going to talk today about the annual report of the National Confidential Inquiry. This is a big day in the calendar for us because our annual report is the moment when we update key figures from relevant to suicide prevention. And when we look at new themes for prevention, particularly in mental health care, and send out new messages about clinical safety. The annual report is based on a 10-year period, the most recent 10-year period. More accurately, it's a baseline year and the subsequent 10 years, in this case 2010 to 2020. During that time, and these numbers are stark, there were over 68,000 suicides in the general population across the UK, of whom over 18,000 were people who were mental health patients in the sense of being under mental health care at the time or recently. Now, the data we present are UK-wide, and the numbers are on the screen. But as you can see, they're very much driven by the larger population in England. Having said that, most countries have similar mental health systems, and the prevention messages are universal. Now, you might ask why 2010 to 2020? Why is that the most recent period? Well, it is partly a reflection of the time span to inquest and then to comprehensive national data collection. It takes time. But it is also that in recording our data, we allocate these tragic deaths to the date when they occurred, not the date when they were registered. And most national data are based on registration dates. And so for 2020 in our data, you can read 2021 in the data from the Office for National Statistics. And so the most up-to-date figures you will see about mental health care. A brief summary of the excellent work of our research team. How do we get the data that we report? Well, we start with a notification from official sources like ONS of all deaths recorded as suicide at inquest or probable suicide. So that's deaths now known as undetermined intent, but previously you may have heard of them as open verdicts. We then check which of those people who died were in contact with mental health services in the previous 12 months. That's our definition of mental health patient. Currently, the figure is around 27% of all general population deaths. Then we send a detailed questionnaire to people who are providing care for that individual. So the clinical team, often but not always the consultant psychiatrist, gives us information about the person, their personal characteristics, about the care they were receiving, and about their impression of what might have made a difference. So that allows us, this very large sample and that detailed information allows us to break down the data we have into characteristics of patients who might be most at risk, into the different parts of the care system where these tragedies occur, and year on year. So the slides you're going to see from now are a representation of our figures. Many of them are year on year, so you'll see change happening during the 10-year period that we're talking about. You'll see many figures, data, statistics, figures going up and down. So we always say on these occasions that these figures are not dry data. They represent real lives lost, preventable deaths not prevented, and families devastated. And even when we talk about rates going down or figures being low, important to stress that no figure, no suicide rate is acceptable. Prevention is vital. So let's start with the headline figure. This is the number of deaths that occur year on year under mental health care. The top line there is the total figure, males and females combined. And as you can see, it's currently running at just over 1,600 people per year. Again, worth pausing on these very large figures, 1,600 current or recent mental health patients. You can see on the slide too that the male figure, so these are numbers, the male figure is significantly higher than the female figure, about twice as high. But in the general population, the figure is 3 times as high. So a reflection of the help-seeking difference between men and women, lower rates of help-seeking in men. Now you might wonder, though, what is the bulge here, just indicated just now, what is happening here? Now, this is the period following the global recession that was referred to earlier. And so it may be that this is a reflection of what was happening to people under mental health care as a result of that wider social pressure. Figures then go up to 2020. I suppose you could say there's a possibility that they've got a little bit higher recently. And now we come up to 2020. 2020, a very important year because it was the first year of the pandemic. And there was a great deal of concern nationally about the disruption to people's healthcare, to mental health care in particular, and how this might affect people who were vulnerable. And so there was a great effort by mental health services to support people who might be at risk. Our data suggests that the number of suicides in people under mental health care did not rise during the pandemic. And that's a reflection too of what we now know about the general population. No rise in 2020. Now, there's one thing that isn't on this slide, and that is what's happened to the number of people under mental health care. Because in recent years, there has been an enormous expansion of mental health services to reach far more people. So we're seeing this relatively flat line here of the number of people who die, but that's happening against a very big expansion in the number of people receiving care. And if you factor that into the calculation, then you get a rather different picture. This is now for England only, and the overall male plus female line is the middle one. And if you go to the beginning of this graph, you'll see that, so this is suicide rates per 100,000 people, so the general population rate about 10. So a figure of almost 100 represents a 10-fold increase in risk. And that's, if you look at mental health textbooks, you often see that figure, a 10-fold increase in the risk of suicide because of mental illness. But since then, the rate has come down, and now is about half of that. Now, some of that change is likely to be an increase in the number of people under mental health care. If you bring in more people into the service, presumably you dilute the overall risk, and the rate of suicide is likely to go down. But the combination of the number staying the same and the rate going down suggests also an improvement in safety. Now, this isn't always the story you hear about mental health care, which faces a lot of pressure and a lot of public scrutiny. But our evidence is that there's been a very substantial fall in patient suicide under mental health care, and part of that is improved safety, a tribute to the efforts of staff. Now, if we take all these years combined, we can say something about the people who might be at risk. And it's worth saying here that what we're describing is not a risk factor study, in the jargon, a case control study. It's a case series study. So we're not looking for risk factors. For that, you need a control population of people who didn't die, similar to those who did, and that just isn't available to us. And so what we have is a description of the issues and problems that people were facing in their lives prior to suicide. And many of those things are established risk factors. So the question we're asking here is, what is it that might have been addressed for these patients that might have made a difference to their risk? What are the things where are the things that we should put our prevention effort into to make a big impact on patient suicide figures? The prevention challenge, another way of putting it. And here we're seeing the overall figures for what are three key areas for our data collection. So first of all, social adversity, high rates, very high rates of socioeconomic stress. So almost half of the people the patients who we report were living alone, almost half were unemployed. Now, unemployment we take, as many people do in epidemiology, as a marker for economic stress. So being unemployed, living alone. So a lot of socioeconomic distress. Similarly, a lot of clinical complexity. People who have a mental health problem, but also have a history of self-harm or alcohol or drug misuse. So thinking of where we put our efforts, a large number of potentially preventable suicides by addressing these social and clinical factors. And then we look at characteristics that suggest marginalization, people subject to exclusion and possibly prejudice. So first of all, ethnic minorities, 7% of our sample, people who died, were from an ethnic minority. And bear in mind that our data suggests that there is no single set of characteristics from ethnic minority groups. They vary greatly, and the prevention challenge varies too. About 5% were people who had recently come to the UK, in the last 5 years had arrived in the UK. That's about 80 patient suicides a year. An important group, often seen as on the margins, not getting access to the supports that might have acted preventively. Now we look also at proximity to care. Proximity to care, the relationship between the patient and the service, a very important aspect of prevention. Clinicians tend to rate preventability as much higher in people who are much closer to the service. And in this slide, we have mapped the timing of last contact before a patient died. And the first two columns showed people who died within 7 days of being in contact. So the figure is about 45%, so it's almost half the patients who die have had recent contact. So let's put this more positively. A large number of people, patients who die, are at least in a position, there's an opportunity for services to intervene. But, and there is always a but in suicide statistics, the rating of risk at these final contacts is usually that risk was low. So it's the problem not so much of lack of contact, but of risk recognition. And if we move to the other end of this slide, people who haven't been seen for over 3 months, it's about 1 in 6 of the patient population, people who've moved away from the service. Now let's follow that theme a little bit further. This is now people who missed their last appointment with services. So that's our marker for people who are beginning to disengage from the care system and might need efforts to keep them in. So this is missing the final appointment, final contact, the planned contact before suicide occurs. And you can see again the same pattern that we saw in the earlier slide, higher figures, then coming down. So this is the post-recession period, and this was a more common phenomenon, but still over 300, between 300 and 400 deaths a year in people who missed their final contact, who gave us the message that they were drifting away from what services were able to offer. And those people have mental health problems, but they often also have additional complexity. They're often unemployed, they often live alone, they often have alcohol and drug problems. So they are about a quarter of the deaths. And if we could make major inroads into this group, then suicide rates in our services would come down. Sometimes, of course, services do make considerable efforts, but in only a quarter of cases were the family of the patient approached to help bring the person back into the care system. Now, we used to have around the country outreach teams whose job it was to maintain contact with this particular group. They've disappeared from some parts of the country, been retained in others. In our studies, they almost always come out as being one of the services that can prevent suicide most effectively. Thinking again of other settings, we're very interested. We've been charting for some years now the certain clinical settings. This is inpatient care. About just under 30% of all patient suicides happen in the acute part of the clinical pathway. So that's as an inpatient or having recently been discharged from hospital in the previous 3 months or under crisis teams. So that one, I suppose, narrow segment of the care pathway is a very important focus for suicide prevention. So here's what's happened to inpatient suicide in recent years. This, of course, is the annual report period, so starting in 2010. But if you go back to when we first began collecting data, the figures were over 200 inpatient suicides. So they've come down quite a lot since then, by about 2/3. And it is partly because we use inpatient care less, but it isn't just that. If we look at the rates, there's a similar fall. This is a genuine improvement in the suicide rate among inpatients, and again, a tribute to the staff on wards who have made safety a priority. But, there is always a but, that improvement seems to have stalled and needs to be reinvigorated. We need to do more about the safety of inpatient services. And of course, it's not just the wards that we're talking about. Just over 1/3 of deaths among inpatients happen on the ward itself. And then, of course, we need to look at physical safety for low-lying ligature points, for example. We need to look at the ward atmosphere, which needs to be the right supportive place for people who are distressed or at risk. But about half of people who die as inpatients die having left the ward on agreed leave, with the agreement of staff. And this is usually towards the end of an admission when people seem to be improving, getting ready to take that step back to the community, returning home. And it's a very important message about how we manage that transition from hospital to community. Transitions in mental health are dangerous. People often fall down the cracks. And here we're seeing people who are apparently recovering, but actually at considerable risk. And that step down to the community is also the key feature of post-discharge deaths. So the period in the immediate weeks after leaving hospital following an inpatient admission. During the lifetime of this report, you can see this extraordinary figure of over 2,000 deaths during this period alone. It is the time of greatest risk for patients, this time of apparent recovery and return. And it's not a uniform risk. The risk is highest in the first 2 weeks. And within those 2 weeks, it's highest on day 3. And so day 1 being the day of discharge. So our services have to be ready to pick up people who might be vulnerable in those first few days. If it's after that, then you've missed the period of peak risk. Now, very, very often for those people, not only do they need early follow-up, but they also need a strengthening of the supports around them. We found that those early deaths are associated with relatively poor social support and the kind of stresses that I've been talking about, social and economic stresses. An important part of stepping down a supportive system of care, of aftercare. Now, in the report, we report these figures every year, but we also introduce theme topics. So these are new areas of concern, often suggested by patients or clinicians or wider society. And so in this report, we have 5 new themes, and I'm going to just briefly refer to each one. So the first one is the one that we've referred to already this morning, and that's the issue of economic adversity. In particular, we're looking at people here who have experienced a recent economic stress. And by economic stress, we mean a new financial problem, which might be a new debt, or it might mean the loss of a benefit, a welfare benefit, or loss of a job, or loss of housing. So a recent economic experience of adversity. And the importance of this group is that we hope to learn something about the support needed for people who might be more vulnerable in the coming cost of living crisis. So again, remember the dates. We've only been asking these detailed questions for a few years, not the whole period, but it doesn't take us up to the current cost of living crisis. So what we're saying here is that previous experience shows that this is who is most affected by economic adversity, and this is the group of people who we need to be concerned about from now. So what do the figures tell us? Well, first of all, that in our patient group, we are seeing around about 400 people with recent economic adversity among the patients who die. So 400, about a quarter of our total patient suicide population. They're often men in middle age, and they're often people who are facing separation, not just on economic grounds, but separation from wider society, a marker for that being their divorced or separated marital status. Then we've tried to do something a little bit more complicated. We've tried to examine differences between people who have had long-term economic adversity. And our marker, remember, is unemployment. So we've said, well, what is it different if you have already faced for some time economic adversity compared to people for whom this is a relatively new stress? And the characteristics are different, and by implication, the prevention challenge is different. For people who are already unemployed when economic adversity hits, they are the group who we've talked about already, facing multiple social and clinical adversity. So alcohol and drug misuse, for example, important. Previous self-harm, also important. But for people not previously unemployed, for whom the economic stress is relatively new, they are a different group. That sense of a sudden crisis developing, people who have primarily depression as their main clinical problem, their main diagnosis, but a recent onset of depression being the hallmark of their clinical condition, and recent other kinds of adversity, including marital adversity. So there's a sense that we have two groups here, people who are facing long-term economic problems and people for whom there is a sudden shock. And it may be that the prevention challenge for these two groups is different. Theme number 2, young people. Now, by young people in this particular part of our data set, we're referring to people under the age of 25. And the blue line, slightly different from the other slides, the blue line has the general population figures marked on it year on year. And you can see what many people know, I suppose, now, which is that we've seen a rise in suicide in young people in the last decade or so, currently over about 700 deaths a year in the under 25 group. Now, on that line, I've superimposed a second line, which is people who were patients by that definition. So this is young people under mental health care. And the idea is to show here that there is a similar pattern. So what's affecting the general population is also affecting people who might be under young people's services. And the figures, an average of just under 150 deaths a year, but again, rising into the most recent years. Most of the rise in both of these groups is in young females, teenagers and female patients. But there are some differences too in the characteristics of young people who die, and they are important to prevention. First of all, they have a lower rate of contact with services. Remember that 27% figure? For young people, it's lower, around 22%, suggesting a possible problem with access to young people's services. The diagnostic profile is also different. And now depression remains the main clinical condition in most suicidal patient populations, but for young people, there has been a rise in those who are known to have an autism condition, an autism spectrum disorder, but also anxiety, sometimes thought of as a relatively mild condition, but in our data, a common part, much commoner than in older people, a common antecedent of suicide in patients. And these are particularly characteristics of our youngest group. So within the under 25s, this is more a feature of under 18s. When we move into the slightly older young people, their risk profile begins to look a little bit more like adults with more alcohol and drugs, that same clinical complexity that I referred to earlier. What they both have in common is a very prominent history of previous self-harm. And so a key service for us in preventing suicide in young people is improving what we offer those who self-harm. Theme number 3, people with a diagnosis of personality disorder. Now, this is not our favorite diagnosis because it can be a pejorative label. We've written extensively about this issue and published a report a couple of years ago about safer care for people with this diagnosis. But we use it because the clinicians that we receive our information from use it too. It's still widely used in clinical practice, so that's why it's in our figures. If you look at the top line here, that's males and females combined, you'll see that we have around about between 150 and 200 deaths a year most years, although we're estimating a further rise in the most recent figures. So what looks like a rising number of people with this diagnosis among the patients who die. So they're becoming, in other words, a bigger part of the prevention challenge. And this is almost the only place in our data where you'll find more women than men in the figures. So particularly in relation to women, where personality disorder is the commonest clinical diagnosis among patients who die by suicide. These are people who have a lot of risk in different ways. History of abuse, self-harm, alcohol, drugs, those same themes again, but also current risks, domestic violence. That's true of women, but it is true also of men male patients who die with this diagnosis. So a very important part of suicide prevention with a lot of risk themes to be addressed. And now we emphasize this because within the mental health system, we have to accept that sometimes patients with this diagnosis do not receive a supportive, safe response. They can be rejected from services, seen as not ill, seen as having capacity. That's sometimes used as a reason for not recognizing risk, seen as impulsive or in control, or acting out behaviorally. This is a group of patients who don't always get the safe care that they are entitled to get. And we're emphasizing the importance of that in today's report. Theme number 4, people from LGBT groups. Now, we looked at this because this is a topic that's very often talked about in suicide prevention circles and in wider society, but actually there's very little data on suicide in these groups. And so we thought we'd use our database to look at what we have and make that known publicly. Again, it's a question we haven't always asked, and so the figures represent the most recent 5 years of our data set. 250 people in the data set as a whole, but though that's bound to be, I would say, an underestimation of the true figure. What do the characteristics tell us about self-harm, about suicide prevention, sorry? Well, first of all, this is a younger group, so a lot of what I've just been saying applies, and a great majority have a history of self-harm. So the importance of self-harm care emphasized again. Quite a lot of crossover with personality disorder concerns. And here we see some difference between the LGB groups and trans patients. A sense that there is more distress and more concern, more risk in the trans patient group. But most of all, what we see is a history of previous and current abuse and intimidation, higher rates than we're finding in our patient population as a whole. So the message about previous and current traumatic experiences, one of the most important in safer care for this patient group. And theme number 5, suicide-related internet use. Most of the time we've asked this question, but not quite the full period. But our figures show the number of patients who've died with having suicide-related internet use, by which we mean using the internet in a way which has some kind of adverse mental health or suicidal content. Now, Ian Russell has given us a very vivid account of the risks of social media to young people. This is a very important part of this issue, but our information is that the risks are wider and the people affected are a broader group. So we're now looking at mental health patients, and in the patient group, it is patients of all ages who are affected by this risk. In our patient group, 80% of those who died were over the age of 25. Commonest group were between 25 and 45. So it's patients of all ages and patients of all kinds, all descriptions, all clinical adversity. It isn't just social media, important though that might be. We find that particularly associated with young patients communicating suicidal ideas on platforms, including social media. But in addition, the broader risks include the kind of information that patients have access to, including information about suicide methods. So obviously I'm going to say relatively little about the detail of this, but it's important to know that that's what kind of information patients are exposed to. And sometimes that is followed by suicide using methods which imply obtaining substances online, substances which are no longer available as prescription or on medication, and so are probably ordered online. So the online risk is in what's written there, but also in what access it gives people to the means of self-destruction. What does this then tell us about future safety in mental health services? Well, in our report, there's a series of clinical messages based on the kind of data I've just been presenting to you, a summary of some of the points on this slide. First of all, greater involvement for family and carers after patients lose contact with the service, a greater focus on that step down between hospital and community, the recognition of financial stress that many patients are likely to face, and the signposting through mental health care to supportive agencies, the crucial role of self-harm services in suicide prevention for young people, the need for new models of care, compassionate, safe models of care for people who receive a diagnosis of personality disorder, the recognition of the traumatic experiences of some LGBT patients under mental health care and therapies that are appropriate to that, and a recognition too of online risk. Online risk should be a routine part of the questions that we ask as clinicians of patients under assessment. And these messages add to our long-standing recommendations on safety. These are the key service and organizational measures that we've found to be associated with that fall. Remember at the beginning, that fall in patient suicide, the commonest associations in the services, known as in our infographic as 10 ways to improve safety. It's the basis of a toolkit on our website. Many people, thousands of people have downloaded that toolkit to audit their own service. And you will see there some of the things I've talked about today. Safer wards, early follow-up on discharge, alcohol and drug misuse, outreach teams, crisis services, treatment of depression, involving families, and a modern, we didn't talk about this in much detail today, but a modern version of risk management. Bear in mind that low risk judgment at final contact. All of this part of our job in reducing patient suicide. Our report shows that prevention is possible, but our findings show that risk is constantly changing. And our message today is that we need to remain constantly vigilant. Thanks very much.
Thank you, Louis, for a really clear and informative talk. I mean, there were so many themes that came through the presentation. Really positive to see that suicide rates look like they've continued to sort of fall between 2010 and 2020. I think some comments in the chat box whether in 2020 we've seen real delays because of the impact of COVID on sort of coroner's inquests. The concern I think that many of us share that children and young people seem to be demonstrating another trend, rising rates in young people, and whether those risks are different really for young people compared to adults. You've highlighted, the concerns about economic adversity. Really interesting to differentiate long-term unemployment from recent financial stresses. And I know that we're going to be joined by Helen in the panel discussion, which I think will be really, really helpful. And then also just about how we improve care for particular groups of people, and you've identified people with a diagnosis of personality disorder as well as people who identify as being LGBT+. So quite a lot, and we're seeing lots and lots of questions that I think we can pick up in the panel discussion. So thank you, Louis. Before I think we break, I believe I'm going to be bringing Nav Kapoor in to introduce the Martin Lawler Bursary Award. So can I hand over to you now?
Thanks very much, Pratibha. Hello from Manchester, everyone. It's my privilege today to be presenting the Martin Lawler Research Bursary Award. Martin was a consultant psychiatrist. He was a suicide and self-harm researcher, and most importantly, he was our friend and colleague, and he tragically died in 2018. With the generous support of his family and with the help of State of Mind Sport, with whom he did lots of work, we've initiated this research awards. I'm delighted actually that Helen, Martin's wife, and Malcolm Ray from State of Mind Sport are joining us today. The award is for early career researchers in suicide and self-harm prevention, in order to foster their kind of career development, really. We had many applications. We spent, the inquiry team, Louis and I, spent a very enjoyable morning going through all the applications. They were all brilliant, a really high standard. But I am delighted to be able to announce the winner. And the winner is Somtu Chico Abiukwe, who is a community pharmacist from Nigeria, currently doing a PhD at the University of Huddersfield. She's going to be using the award to fund attendance at the YASP conference, International Association for Suicide Prevention, one of the main conferences in suicide prevention. And we particularly loved her application because of the novelty. It was about pharmacy in suicide prevention, and the fact that it was based in a low and middle income country where we know the majority of suicide deaths occur. So many congratulations, Somtu. And if you want to congratulate her, I believe she's attending the conference. You can congratulate her in the chat. Thanks very much. I'll hand back to Pratibha.
Thank you, Nav, and congratulations, Somtu, and to everyone that applied for that particular award. I mean, I think, as you said, Nav, a great opportunity to support suicide research internationally as well.